Hi, my name is Ben Lavon. I'm the Chief Scientific Officer of Fluidda, and today I'm going to talk to you about two of the posters that we're going to be presenting at ATS. The first one is entitled The Effect of Extrafine Medium-Dosed Inhaled Corticosteroid Long-Acting Beta-2 Agonist, Long-Acting Muscarinic Antagonist on Distal Airway Indices using Functional Respiratory Imaging in patients with symptomatic COPD on ICS LABA. And while that title is certainly a mouthful, the actual experiment we did was fairly simple. So the reason we were interested in looking at this, a lot of COPD subjects, particularly those with fairly advanced COPD, end up on what are called dual therapies, an ICS or inhaled corticosteroid and a LABA, long-acting beta-2 agonist. But the ICS, the inhaled corticosteroid, has a significant risk of side effects when used for a very long time. So there's a lot of motivation to look for either ways to avoid using an ICS or for an ICS that is lower dose. So in this study, what we did is we took COPD subjects who were symptomatic, they still had symptoms on their dual therapy, and we switched them to an ultrafine DPI ICS LABA combination, where the ICS was medium dose, and we added a LAMA, or long-acting muscarinic antagonist. And what we were interested in was seeing whether there were changes on their distal airway geometry and lung ventilation using FRI. So we had subjects come in for a screening visit. They were switched to a high-dose ICS LABA. They weren't already on one, and they spent 6 weeks on that regimen. Then they came in for another visit. At this visit, they had spirometry performed, they had body plethysmography performed to measure their lung volumes, and they had their symptoms assessed using what's called a CAT score. They had CT scans before and after being administered their first dose of the study drug, which again is a medium dose ICS, and then a LABA and a LAMA, and an ultrafine DPI formulation. They spent 6 weeks on that treatment, and then they came in for visit 3, and they had the same visit and they had the same measurement repeated. So what we ended up finding was that in these subjects, there was a significant increase in the distal airway volumes and a significant decrease in their distal airway resistances. But we only observed that change at FRC, or at expiration. At TLC, which is what we assumed we would be looking at as our primary outcome measure, we didn't see those changes. In addition, we also saw that when we looked at the change from before the dose of the study drug to after, both at visit 2 and visit 3, there were significant acute changes. So again, increases in distal airway volumes and decreases in distal airway resistance. So what we can conclude from this is that there are significant acute changes associated with the administration of a bronchodilator, not a big surprise. There are significant differences in the appearance of the expiratory airway geometries over 6 weeks of treatment on the new study drug. We didn't see any worsening. And so what we assume is that for subjects who are symptomatic on a high-dose ICS LABA combination, switching to a medium-dose triple therapy might be an effective strategy to help avoid some of the unpleasant side effects associated with long-term high-dose ICS use. And in fact, we did see a small and borderline significant increase in spirometry and FEV1, and we did see a symptomatic improvement as assessed by CAT score.